Let's continue on with modes. APRV, or airway pressure release ventilation, is a variation of the PCIRV. These patients are allowed to breathe spontaneously at high and low levels of CPAP. Spontaneous efforts may be pressure supported. Most of the time is spent at the high CPAP level with brief periods of release to the low CPAP. During the release, the patient exhales passively. When the pressure is restored to high CPAP, it causes a mechanical inspiration. Often fewer hemodynamic side effects as compared to PCIRV, and less sedation is required, because most of the time you don't want these patients sedated at all. You want them breathing spontaneously. Here's a graphic of APRV. Here's the high CPAP setting, the low CPAP setting, the high time, and the low time. Pressure support ventilation, or PSV. This is a spontaneous mode of ventilation. It's patient triggered, pressure limited, and flow cycled. Flow cycle may be factory preset or adjustable. The primary idea of pressure support ventilation is to overcome the work of breathing that may be caused by the endotracheal tube, secretions, or bronchospasm. Patient has control over the respiratory rate, the inspiratory time, and the flow. The tidal volume is determined by the level of pressure support that's set, the patient's effort, static compliance, and resistance. This may decrease the respiratory rate, the work of breathing, oxygen consumption, and increase tidal volume. And that's generally the idea. And patients like this mode quite well. So it's much better than having no pressure support and having to breathe through the airway without any additional assistance. A variation of the pressure support ventilation is the volume assured pressure support. This is a dual control mode where the patient initiates all breaths, which most resemble volume control with constant flow. If the patient demand is greater than the set flow, then the breath becomes a pressure breath. The breath ends when either number one, volume is reached, or number two, if the volume is exceeded when the patient flow falls back to the set flow. The other Kazmarek book, The Essentials of Respiratory Therapy, has a chapter on ventilatory modes. I would suggest that you look in that. He does a very good job of breaking these down, these different modes, and he also identifies which of these adaptive modes, adaptive meaning that the machine makes adjustments depending on what's going on with the breath in the patient. Some of them adapt within the breath itself. Some of them adapt between the breaths, from breath to breath. So you might go over there and look and read in that chapter. He does a very good job of describing them. Continuous positive airway pressure, or CPAP. This is a spontaneous breathing at elevated baseline pressure. Positive pressure maintains higher alveolar inflation used to reestablish the FRC in low FRC states. This may reduce the need for high FiO2s, reduce shunt, and improve VQ mismatch. Adaptive support ventilation, and again, this is one of those adaptive modes. It's an automated dual control mode where support varies based on the patient's effort. You input the ideal body weight, the high pressure alarm, the PEEP, the FiO2, the rise time, the flow cycle percentage, and the percent predicted minute ventilation desired. The ventilator makes adjustments based on an Otis ideal ventilatory pattern. That's a engineering type idea. Proportional assist ventilation, or PAV. In this mode, the practitioner sets the proportional assist up to 80% of total effort. What this means is that it'll take over 80% of the work of breathing if that's what you have it set at. The ventilator determines the airway pressure, the flow, the tidal volume, the inspiratory time, based on the effort and the lung mechanics. The patient affects everything, as the only set parameter is what the ventilator will perform as a fixed proportion of the work. It has very little data to support the use. I think I've mentioned before that the mode really doesn't change the outcome for the patient. It might make them more comfortable, but it doesn't make them more successful. You also have a potential for runaway ventilation caused by leaks or overestimation of elastance and resistance. Automatic tube compensation. This calculates the resistance associated with the artificial airway, and so that's what it's based off of. And it attempts to adjust the airway pressure to keep the tracheal pressure constant at baseline. And the goal here is to eliminate the work of breathing that's imposed by the endotracheal tube in the circuitry. So the ATC percentage is adjustable to compensate for as low as 10% or up to 100% of imposed work. You also have the option of applying it on inspiration or expiration. If it's applied on expiration, this may cause early airway closure, as the ATC accounts for work of breathing imposed by the ET tube. Some consider equivalent to electronic extubation. Just a couple of thoughts about the ATC. Most of the time, we don't have to have an order to engage the ATC. However, when you have pressure support ventilation, if you have the patient that you're trying to wean, and you have the ATC engaged, and then you have pressure support ventilation, well, the idea of both of these modes are to overcome the resistance of the airway. If you have both of them engaged at the same time, it might give you a false picture of the patient's capabilities. So what you need to do is you need to have only one of these, and so you need to go and look and make sure this is either turned off or turned on, whichever one you want, whichever one you're going to use. Make sure you only got one of them running at a time. We've talked a little about dual control modes with a volume target. This is where the pressure, it's a pressure controlled breath, but the volume is a target. And so it makes between breath adjustments, always moving toward the target. So volume support ventilation is one of these. You set the target tidal volume, the FiO2 and the PEEP, and the high pressure alarm. The pressure support will volume target. In other words, the pressure will be adjusted from breath to breath, moving the volume towards the set target. If pressure support delivers an inaccurate tidal volume, the following breaths adjust a maximum of 3 centimeters of water until the volume target is reestablished. And it's a constant adjustment from breath to breath to breath. Another dual mode is PRVC, or pressure regulated volume control. Again, where the volume is the target and it's pressure regulated. In other words, it adjusts the pressure to achieve the volume target. So if the target is not reached, the next breath pressure will adjust a maximum of 3 centimeter increments per breath until target volume is attained. You have to be careful here because the patient with a strong drive may receive diminishing support with an increased work of breathing. Patient positioning to optimize oxygenation and ventilation. Frequent turns are required to avoid atelectasis, hypoxemia, secretion retention, and pressure sores. In most cases, that's about an every 2-hour schedule. So you turn them every 2 hours. If they're on their back, you turn them on the right side. 2 hours later, you turn them on the left side. 2 hours later, they're on their back again. And so just keep them moving. And again, that's the easiest way to prevent that stuff. And so that's part of our responsibility too, especially if it's a labor-intensive turn. We're not necessarily in there to help turn the patient, but we're in charge of the airway so that the airway doesn't become dislodged. There are the options of the kinetic beds. They typically may help, but they're very expensive to rent them or even buy them. I think now most places are going more to a mattress instead of a whole bed, where a bed costs you, $25,000, or it costs you $250 a day to rent. It's been my experience that they're very beneficial, but they're just very expensive, and so I think the mattress, the inflatable mattress, is a cheaper alternative. If you have a patient that has unilateral lung disease, you place the good lung down as much as possible. So this improves the ventilation perfusion ratio and should improve oxygenation. So this brings up a good point. If you go in there and you're having to move this patient every 2 hours to prevent the hypoxemia and the secretion pooling and whatnot, and you go in and turn them, and 5 or 10 minutes later you're summoned back to the room because the saturations are now in the 80s or 75 or something like that. You have to consider that the position that they're in is the culprit. And so if you encounter that, what you do is you put them back in the position where they're being successful. And so you limit the position that caused the hypoxemia. Occasionally you'll get a patient that requires prone positioning. This is where they're laying on their stomach. And in the Essentials book, Kazmarek refers to the prone positioning as this is not a cyclic type positioning. If you put them prone, you leave them prone. He also points out that mammals sleep on their stomach. Do you sleep on your stomach? Well, most of us do to some extent. And when you do, it improves your ventilation perfusion in your lungs. You may want to make sure that your abdomen is free to move when you're in the prone position. And of course, you got to guard the airway big time. You got to guard all the lines, the Foley, the IVs, the airway. The airway's a big one for us, right? Make sure it doesn't become dislodged. You also have to be able to suction them too, so you have to have access to that airway. And so this is a very labor-intensive, kind of abnormal type setting, but it works. So we have to live with it and deal with it and learn how to operate with the patient in the prone position. Now, minimizing cardiovascular effects of positive pressure ventilation. Early studies show marked reduction in cardiac output. The amount of reduction is directly related to the pressure applied. The more the pressure, the more the compromise. Positive pressure ventilation causes the plateau pressure to become positive, and so that's what causes the problem. The intrathoracic veins are compressed, increasing CVP. This impedes the venous return and causes venous pooling. The cardiac output decreases within a few beats. Increased ICP with a reduction of cerebral perfusion may lead to cerebral ischemia or hypoxemia. However, typically healthy persons are minimized by autoregulation of blood flow. Compensatory mechanisms minimize the cardiovascular effects. In other words, they increase the heart rate or their systemic vascular resistance and blood to core organs. Pulmonary vascular pressure is increased due to the compression of those capillaries. The blood flow is compromised and the pulmonary vascular resistance is increased. Normally, positive pressure ventilation has minimal effect on all the above because we can compensate for it. Or if we use it within reasonable limits, it doesn't cause a problem. If alveolar distension occurs due to high tidal volume or excessive PEEP, Blood flow is impeded as the capillaries are compressed between the overdistended alveoli. Increases in residual volume, afterload, and decreases cardiac output. This increases the right ventricular afterload and decreases the cardiac output. The stiffer the lungs, the more this effect is minimized. So in relation to compliance, the higher the compliance, the more likely you are to experience cardiovascular side effects. So typically in ARDS, or the low compliance diseases, if you have blood pressure problems, and many times you do, it's not related to the mechanical ventilator. It's usually related to the sepsis or whatever initially caused the acute lung injury or the ARDS to begin with. The right and left ventricular function. With the normal cardiovascular system, you typically don't have any problems here. But some conditions that cause impairment are hypovolemia, where you don't have enough blood volume, excessive tidal volumes, or PEEP. So if you don't have enough blood volume, many times what you can do is you can do what they call a fluid challenge to see if you can maintain your blood pressure and your blood flow. So give them a liter of fluid and see if that improves. If it doesn't improve, give them another liter. Then if that still doesn't work, then you may need to start some blood pressure medications. But that's called a fluid challenge. Effect with left ventricular dysfunction. This may improve cardiovascular function to decreased afterload. Endocardial blood flow may be impeded, determined by the delta P between the diastolic and wedge pressure. Decreased by excessive PEEP, mean airway pressure, high tidal volume, and long I times. The cardiac output, cardiac index, and systemic blood pressure. Recall that the cardiac index is the cardiac output compared to the body surface area, and is normally the value for the cardiac index. The way I remember it is it's very similar to the resistance. It's about 2.4. I think it's 1 to 2.4, 2.5. So again, if you have a normal cardiovascular system, you typically don't experience any problems here. But if you have a high mean airway pressure, this may decrease all of these. And ways to minimize or avoid these effects are adequate fluid balance, proper management of positive pressure ventilation, the lowest mean airway pressure and PEEP possible, and then use of blood pressure medications or vasopressors. The most common cause of hypotension in positive pressure ventilation is sepsis. The mean pleural pressures, clinically monitored by following the mean airway pressure. They certainly have a linear relationship. The higher the mean pleural pressure, the greater the cardiovascular effects. Effects are minimized in non-compliant lungs, stiff lungs seen in the ARDS type patients. Moderate increases in mean pleural pressure have minimal effects in most patients. If the patient is hypovolemic, however, a small change in MPP may cause a serious decrease in cardiac output. So again, a fluid challenge is in order. So how do we decrease the mean airway pressure? Well, the mean airway pressure is affected by the respiratory rate, the tidal volume, the inspiratory time, if there's any pause time, expiratory time, the I ratio, the peak inspiratory pressure, the PEEP, and the inspiratory flow pattern. In other words, pretty much by everything, right? Changes of the above to decrease the mean airway pressure. So what we're trying to do is we're trying to limit the size of the breath and the PEEP and the I time just to what we need. We don't want to put excessive pressure or volume in the lungs because it does affect the mean airway pressure. And so remember that the bad part of the mean airway pressure is that it affects the cardiovascular status. So if the PaO2 is high, reduce the PEEP and follow carefully to avoid desaturation. We have to oxygenate them, right? So we can't turn down the PEEP to where they're going to desaturate. Increase compliance. You can also increase the PEEP there, and use of diuretics will also improve that. Decrease the tidal volume or the pressure control level. Decrease the eye time so that the pressure stays at baseline longer. So you're at peak pressure for less time and you're at base time longer. That certainly decreases the mean airway pressure. And then another change from assist control to SIMV or pressure support if the patient can tolerate it. Fluid management and cardiac output. In the face of sepsis, high PEEP and mean airway pressure, preload and cardiac output may decrease, thus worsening the delivery of oxygen. So fluid or blood administration is used to maintain the cardiac output, the fluid challenge, right? And then if your fluid challenge doesn't work, then your drugs to maintain the cardiac output and blood pressure. So the first line is the fluid administration, except for CHF. You have to be very careful if they have a history of CHF. You don't want to overload them. If you do, you'll get the pulmonary edema. In shock, you use the fluid to achieve a CVP of 8 to 10 or a wedge of 18. Persistent shock, use dobutamine, which increases the strength of the contraction in the heart. And if blood pressure is low, you use dopamine.